Thank you for joining us for another exciting edition of the Computational Toxicology Community Practice. My name is Sammy Hance, and I am a student services contractor here at NCCT. Today we'll be hearing from Dr. John Wambaugh, and he will be talking about the High-Throughput Toxicokinetics R Package. Before we get started, I just want to ask everyone to please mute their lines. You can accomplish that by hitting #6. If you have any issues with the audio, please just let us know in the chat, and we'll try our best to get those resolved for you.
Do allow up there.
There we go. Cool. Share my screen. Does that work now? Okay. I don't know how That's about to get bad. And so now we should. There we go. All right. Sorry about the technical difficulties.
That's fine. All right. Good morning, everyone. Thank you for. Okay. Let me just swap this. Should be good. All right. Yep. Thank you for tuning in. I will do my very best to leave time for questions at the end. If I don't, feel free to email me, wambaugh.john@epa.gov, or if you're obviously in the room, just throw a shoe or something at me and I'll stop talking for a little bit. So yeah, I am John Wambaugh from the National Center for Computational Toxicology, and I'm here today to tell you about the High-Throughput Toxicokinetic, or HTTK R Package. So I'm actually going to show this slide twice. This work on the HTTK package is the result of a very large team. Most notably in the lower left, there's Rusty Thomas and Barbara Wetmore, who kind of got the adapting in vitro for environmental toxicokinetics going almost 10 years ago now. And then in the upper right, there's the Cyprotex team, who's done an incredible amount of lab work to make all this possible. And so, and then there's any number of, not any number, there's a finite number, but some very good postdocs, graduate students, and student contractors who have worked with me on this over the years. And so we'll talk a little bit more about all the different projects that add up to HTTK throughout this. So just as background, the National Research Council, or National Academy of Sciences official opinion on how to do human health chemical risk assessment says that you basically need to have some idea of the chemical hazard, some idea of what actual exposure happens, and quantification of the chemical dose response. So if you get exposed to this much, this effect happens. Unfortunately, there are literally thousands of chemicals in the environment, in commerce, and at least hundreds in all of us that we don't have either the hazard or the exposure in from. And this shouldn't be a surprise to the CompTox communities of practice. It's kind of the reason we're all here on the line. And so what we really need is, we want to do one of these diagrams like on the right here, where it's, we might have some idea of the dose or the dose intake rate that causes toxicity, and that would be a combination of reverse toxicokinetics and in vitro screening. We might have some idea of the exposure rate, and these numbers might be relatively uncertain. We might not know them as well as we want. They might have a confidence interval around them. But if we've properly quantified that uncertainty, and that's always the question, did we get it right? But if we have properly quantified the uncertainty and the two numbers, still the distributions don't seem to be overlapping, that's a lower risk priority chemical. It's just less interesting. Whereas if we do the quantification and there's some plausible chance of an overlap, that's a more interesting question. Now, that doesn't mean if you go and do a further study that you won't still find a margin there. It just means, right, the chemical over here is more interesting than the chemical over there. So to do that, we need high throughput hazard. That's what CompTox has been about for the last 10, 15 years. We need high throughput exposure forecasts. There are some, there's various different approaches. And then there's high throughput toxicokinetics, and that's what we're talking about today. All right, next slide. There we go. So yeah, and this is just, again, reviewing kind of, we have three pieces that we need. Technically, we need dose response, which involves both toxicokinetics and toxicodynamics. I have no idea how to do toxicodynamics in a high throughput manner, so this is the last time I'll use that word. But basically, hazard is screened, it is really bioactivity that's been identified in vitro. And so what we want to do is in vitro in vivo extrapolation. We want to be able to go from an in vitro effect to a predicted in vivo effect. Oh, I'm sorry, I do have toxicodynamics here a second time. Well, I'll get off this slide real fast. But the general idea is, in the past we went from rodents in vivo to humans in vivo. Now we're going from human in vitro. Most of the ToxCast and Tox21 assays are based on human biological material. So we're cutting rodents out of the picture here. And we want to look at how we can predict in vivo. Now to do that, rodents have still been really important. And we've done some research using rodent in vitro information to predict rodent in vivo effect as an analogy to see how we do with human in vitro to human in vivo effect. And so we need to know both of these things. One thing I'll say is that we did a community of practice about 4 months ago in February on one approach to doing high throughput exposure. National academies have a whole outline of how exposure science in the 21st century should be done in parallel to toxicity testing in the 21st century. But again, we don't really have time to talk about that today. Okay, so if we want to do this little cartoon diagram, which we variously call the Pinocchio plot because they look like noses, and I've had a number of people urge me to make these more normally distributed, but I actually like the idea that they're non-parametric distributions because, uncertainty is actually kind of messy. It's not well behaved. But yeah, so the nose gets longer as you, tell less truth or get more precision depending on what version we're talking about. But the issue is if we want to do this comparison, we need to be able to use toxicokinetic data. We need to be able to go from an in vitro concentration and relate that to the dose that you would need to have. And that data just doesn't exist for an arbitrary chemical, for most chemicals in commerce. We just don't know that. And so that's where the higher throughput toxicokinetic methods pioneered by Barbara Wetmore, Rusty Thomas, and the very first paper had Dana Rotroff as the first author. They've been looking at this. And so these methods, this is just like ToxCast. They're adapting in vitro methods that were developed by the pharmaceutical industry to an environmental problem. And so in the pharmaceutical industry, and we'll talk about this more, these methods actually work pretty well. So this Long et al., or not even at all, Long 2010 says that if you do a clinical trial, you're going to get within about a factor of 3 of the actual dose that you need using these in vitro methods. So the primary goal of HTTK is to do this in vitro in vivo extrapolation. And that's to allow you to understand ToxCast in a context that actually means something. I've said several times, it'd be very difficult for the EPA to issue a health advisory to everyone to avoid 2 micromolar of chemical X in your liver. That's just not an interpretable thing. You get laughed at for doing that. This is going to allow you to translate 2 micromolar in the liver into a dose that you could try to tell people, don't eat this many, more than X servings of fish or whatever it is that would have your chemical in it. The secondary goal, and we'll talk about this more too, is to provide an open source data and modeling framework for evaluation by the broader scientific community so that we can use these for regulatory decisions. Okay, just a quick review. What sorts of data do we get for in vitro toxicokinetics? Well, the first assay uses cryopreserved hepatocytes, and it uses a 10-donor pool. And the reason for that is that everyone's liver is different both because of our genetics, but also because of environmental choices we make. If we're a smoker, we've upregulated certain enzymes. If we consume alcohol, if we eat certain things, if we do, our enzyme expression levels will be different. And so to get an average person's liver, we actually use a pool that's been crafted from multiple donors to try to have the typical levels of expression of all the enzymes on average. Then these are just in a suspension in a dish, chemical is added, and then samples are taken over time, and we look at the disappearance rate, if any, of the parent chemical over time. So this is it's a simpler assay than some metabolic assays. We're not quantitating what metabolites formed. We have no idea. We're just looking, does the chemical disappear over time, and we're estimating a rate from that. And so this is a really useful assay, and I do want to point out that it requires analytical chemistry because it's not like you can just measure a fluorescence to see how much chemical is there. You need to actually quantitate how much chemical is there over time. The second assay that we use is rapid equilibrium dialysis. This is one of many available assays, and actually Texas A&M just put out a paper on looking at other approaches to measuring protein binding, but this has worked pretty well for a lot of our chemicals, and we have some corrections that help it work better for high log P chemicals. It'd still be better to have data on that. But what we get is it's an assay where you have two wells separated by a membrane. That membrane is permeable by small molecules, so the sorts of chemicals that we're interested in, but it's not permeable by proteins. And so human plasma protein is added to one side, and then you get free chemical on the left-hand side and free chemical plus the chemical stuck to plasma on the right-hand side after equilibrium. And that gives you a fraction of how much chemical is unbound in the presence of protein. Again, you need to be able to measure the chemical concentration on both sides. This has been done initially in a pilot back in 2010, published back in 2010 for 35 chemicals. Barbara Wetmore had two follow-on papers, 204, 163, and we've just recently submitted a paper where we have an additional data on 389 chemicals. And I'll go over those, some of that results toward the end of this talk. Once you have that in vitro data, we use it with, we can use it with a relatively simple model for steady state plasma concentration. And so this may not look simple to you, but the general idea is that you have something in your glomerular filtration rate, basically how much flow there is through the kidney, free fraction of the chemical, that's one of the two things you measure in vitro. You have the blood flow into the liver, free fraction of the chemical again, and then you have the hepatic clearance that you measure. This is sorry I keep jumping here. This is the scaled up clearance rate. I need to turn into a laser pointer here, sorry. Give me just 1 second. Pointer options, laser pointer, great. All right, so the CLN and the F-up are both directly related to the two numbers that we measure in vitro. Everything else is physiology. And so even though that looks maybe not like the friendliest equation you've ever seen, the whole denominator, this whole bottom side is just a number. Each chemical in each person has a specific value for that number, but it is just a number. It could be 3, it could be 40, but it is just a number. And so then this equation becomes my plasma concentration is equal to whatever the dose rate I got divided by that number, whatever the value is. So that means this equation is linear. So if I increase the dose, my steady state concentration goes up. Now that's true for this model. That's not necessarily true for any chemical. There's all sorts of things that we're not taking into account. But this is a really convenient model because we can take this daily dose and the steady state concentration. So a dose gives us a steady state concentration. Well, we can reverse the axes. Then we can go from a steady state concentration to a daily dose. We can do this with an in vitro AC50. We can do this with an in vitro ACC. Any concentration you want, you can use this linear model to come up with a predicted linear dose that would cause that concentration. And so that's what we call the reverse dosimetry in vitro and vivo extrapolation. It's a very simple model for in vitro and vivo extrapolation. However, even that simple model can be really complicated. So in vitro assay, you have a chemical. It might have evaporated. It might be binding to the plastic. You don't know how it partitions into the cells. You don't know what else it's bound to. And then in vivo, you don't know, is the chemical in the plasma, is it in the blood, how quickly did it come to the steady state concentration? So then you can start to ask questions like, should I be using the free concentration in the cells and relating that to the free concentration in the tissue, or I don't know, maybe something else? There's a lot of possibilities here. And the whole point of this consideration here is, one, to say in vitro and vivo extrapolation is not done, nor is it a simple linear thing, but it's really complicated. Greg Honda, in a paper just published in 2019, looked at, and this is for reverse dosimetry, he looked at all of these combinations here are different ways, different assumptions about this diagram. What concentration should we relate to what? And every time he was looking at, well, how well do we predict in vivo effects from in vitro effects? And so looking over the ToxCast assays, he checked 3 different situations. One where you just took the AC50 and you tried to correlate that with the in vivo effect. The second where you just did random toxicokinetics for a random chemical. So maybe my actual chemical is bisphenol A and I randomly pick 10 times different chemicals. How often does that work? And then if you actually use this high throughput PBTK model for the specific chemical, how often does that show better correlation than the other two models. And what he found is that while there's no single winner here, I mean, okay, there's a single winner. You know, the Armitage et al. Model seemed to help in this particular case, but it's not clearly statistically better than a lot of the other ones. But the big winner here is PBTK, because it really looks like using a PBTK model to do some in vitro and vivo extrapolation is worthwhile. It's just very hard to say exactly how we should do it right now, and partially that's because we just don't have the data sets we'd want to prove that exactly. We can develop them over time, and Tox21 has a project working on that, but we're not there yet. So do I really have to think about all of that stuff if I just want to go from in vitro to in vivo? Because, you know, that sucks. No. Well, yes, but no. You don't have to. This is what we do with the HTTK project, is we try to make it a little easier. So what you would have to do if you want a Monte Carlo oral equivalent for 0.1 micromolar for acetochlor is load up the HTTK library and say calculate the oral equivalent. And we will use a default model that we have clearly spelled out. There's a ton of code going on there. I want you to think about all the stuff in that diagram that we don't really want to think about. That's all in there. But if you're a bioinformatician and you just want to use a reasonable model, this one line gets you from micromolar to mg per kg per day. And that's really the goal of this. This tool was originally developed for postdocs in the NCCT who are doing bioinformatics. They don't necessarily want a giant course in toxicokinetics. They just want to do the best thing that they can. And so that was our initial end user. All right. So if you have concentrations that are bioactive in vitro and you have high-throughput toxicokinetics, then you can do in vitro and vivo extrapolation. And that gives us these sorts of diagrams like this. This is what we call a bioactivity to exposure ratio plot. Note, first, this is on a log scale. So this is 10 to the minus 10 mg per kg per day, 10,000 more, so 10 to the minus 6, up to 100 mg per kg per day. The bioactivity is not terribly specific, and that's like the cartoon we talked about at the beginning. It has a distribution. And the exposure is not terribly accurate. And actually, if you think about it, these exposures, this is the central estimate, and this is the upper 95th percentile, so it also goes down. You know, that's uncertain to, 100 million times or something like that. And so a reasonable question I was asked early on is, what are you supposed to do with this sort of information? Well, if you look at this diagram, there's actually only a small subset of chemicals where it's even in the realm of possibility that for the average person, toxicity and exposure are overlapping. Whereas over here, it doesn't seem very likely for the average person. In fact, there's actually, when you get all the way over here, we're got 8 orders of magnitude between the two numbers. So this number is really uncertain, but it's certain enough to allow me to say I'm not really interested in that chemical relative to this chemical over here. So if you'd like the HTTK package, it is publicly available. It is on CRAN. That's the repository for the open source R language. So R is a language for doing statistics. You can get online. There's help files. There's everything you want. All of our data tables, everything's up there. So what can you do with this? Well, first and foremost, you can predict internal tissue concentrations from a dose regimen. You basically have toxicokinetics. That's what toxicokinetics is all about. I take a pill or I get a certain exposure. What are my tissue concentrations? You can do in vitro to in vivo extrapolation. There's a peer-reviewed paper in the Journal of Statistical Software that provides a how-to guide to do that. You can use the built-in chemical library that comes with it, and we'll talk more about that, but we're approaching 1,000 chemicals built in to that, or you can add more chemical information. So, and there's instructions how to do that in the paper, but basically if you have additional chemical data that you would like to use internally and you'd like to use our public model on it, you can do that. You can use specific demographics in the population simulators. So they're based on the U.S. population. However, the U.S. population is relatively diverse, so you could actually try to approximate other populations using the U.S. population. And you can actually control the random number generator. And this is not something that we added to HTTK. This is just true of R, but there's a function called set seed. So Monte Carlo is a stochastic process. That means every time you run it, you're going to get a different answer, unless you use the set seed function. And you give it the same number in set seed, the Monte Carlo will give you the same answer again. You may all think that's obvious, or you may not care. That's really useful for a regulatory setting, to be able to say, I can go back 10 years later and get the exact same answer, even on a stochastic process. All right, so I've kind of implied the definition, but I haven't really spelled it out here before. What I'm calling HTTK is in vitro toxicokinetic data. That's presumably a little bit higher throughput than the traditional animal study, where you might use a cohort of 100 animals and take samples over time, lots of dosing. That's expensive and a little bit slower. And some sort of generic toxicokinetic model. And the one I've shown you so far has been this one compartment model where basically you have a gut and you absorb it into the body and you excrete it. And so a generic model plus in vitro data is what I'm calling high-throughput toxicokinetics. That's HTTK. However, the generic model does not have to be a one-compartment model. And so HTTK currently includes a generic physiologically based toxicokinetic model. That's where each compartment corresponds to volumes of tissue in the actual body. There's blood flows that are physiologically based between the tissues. However, on the whole, it's still parameterized with those two numbers, the fraction unbound in plasma and the intrinsic hepatic clearance. So the only way the chemical leaves the body is still glomerular filtration in the kidney, excretion from the kidney, or metabolism in the liver for now. There is absolutely nothing new about the idea of generic PBTK models. The first paper I could find, and I have not done an extensive search on this, but goes all the way back to 1996. There's a generic model. There's certainly lots of others over the past 20 years. And then there's the big boys. There's Simulations Plus, there's GastroPlus. That's been available for, it seems like 15, 20 years now. And SimSip, population-based simulator. Both of these include a generic PBTK model that can be parameterized from high-throughput toxicokinetic data. So you might reasonably be asking yourself, why in the world did I build another generic PBTK model? And actually, initially, we did not build another one. Barbara Wetmore's initial work was all with SimSip, and her first several papers used SimSip. And SimSip's a great product. ADMET, Predictor, GastroPlus are great products. There's the model equation generator from the UK Health Safety Lab, and there's something called Indus ChemFate. And then HTTK is on the right-hand side here. And I know there's other generic models out there. However, there were certain properties that we really wanted in our package, in our generic PBTK model. One of those is that we wanted integration with a statistical language. We wanted to be able to do statistics on it, and I'll talk more about that in a little bit. But we also wanted to have a library of chemicals that we care about. This Indus ChemFate comes with 15 environmental compounds. The others don't, except that SimSip has some clinical drug examples, whereas right now we're at 933 ToxCast chemicals, so and some pharmaceuticals. So basically that gives us a built-in library where everybody's working from the same data. And that just is helpful. There was a time when actually the other software didn't have batch mode. This table was a little more damning and a little easier to sell HTTK on, but batch mode has been added to lots of things. But still, that's why we set out to build this. All right. Now we have one other requirement. So Eva McLanahan, who at the time was working in our National Center for Environmental Assessment at the EPA, led up a workshop at the Society of Toxicology meeting and had a nice paper in ToxSci on physiologically based pharmacokinetic modeling, why being published is not enough. And their point, and some of the people in the room here will know this very well, is that being published in a peer-reviewed journal is a mark of good science. Unfortunately, it's rare that that journal article captures everything you need to know to recreate the PBTK model. And SIA had already had a lot of experience trying to use these in regulation, and they end up going back and forth with the author, trying to get the code, trying to get everything working, and it was complicated. So we already knew that getting a model and getting the code and fully understanding it for a regulatory decision was hard. And then in 2013, there was actually an executive order from the White House that the federal government should be using open data formats, and they even, how often do you get an executive order that mentions GitHub, but they are actually describing, put your code out there, let people see it, let people kick the tires. The default state of new and modernized government information resources should be open and machine readable. Now, different federal agencies have interpreted this slightly differently, but at EPA, this is part of the reason that they have stepped away from using tools like SimSip and GastroPlus for decision making because they want to be able to see the code. So on one hand, SimSip is probably always going to be better than us because they have a 20-year head start and all sorts of data and they're working on pharmaceuticals. On the other hand, we have to show you all of our code so everybody gets to pick over it and see what's going on. And so that's where HTTK fills in a gap for us. So we are on GitHub. You can go. There's actually two different repositories, but this is the one where you can see publicly and you can see all the comments and the typos and or the lack of comments. Actually, that's the more damning one, right? Yeah, anyhow, I don't write the cleanest code, but fortunately a lot of gracious people have worked with me to make this a little more readable. Okay, throughout this set of slides, I include some example slides. Unless somebody really has nothing else to do today, I'm not going to go through them in great detail, but basically anytime you see the big example at the top, know that that's a set of code that you should be able to cut and paste into R and run. And so, for instance, we do oral equivalent doses. Now, we do have a function that can retrieve published numbers from tables. So if you want what Wetmore 2012 said the oral equivalent dose was for acetylchlor, and you happen to know the CAS off your head, top of your head, you can also use just the word acetylchlor. You can use the get literature oral equivalent, or you can use our new latest version of the model and calculate it. Both of these will give you answers. They just give you slightly different answers. Now again, this is Monte Carlo here, so unless you use set seed, every time you run this, you'll get a slightly different answer. All right, here's another set of examples of how we would use these functions. You can do interspecies extrapolation. So Barbara Wetmore in 2013 and Greg Honda this year have published papers where there's rat literature values for steady state plasma concentration. You can retrieve those. If I try to get literature values for mouse, you will get an error message because, to the best of my knowledge, nobody's done this in mouse yet. Now, I know there are several groups looking at different species, and once those literature data are out there, it's pretty easy to add it in. On the other hand, you can use our package to extrapolate to mouse. And so initially, if you try running this one, you'll get an error because we don't have in vitro data for mice. But if you say default to human equals true, everywhere it doesn't have a number for a mouse, it will use the human data. So it'll use the human fraction unbound and the human clearance, but a mouse physiology. And so it'll allow you to extrapolate to mouse, monkey, dog, rat, and rabbit. So we want to do statistical analysis. If we're going to use HTTK for some sort of public health protection, we need to have some sort of confidence in our predictive ability. And so in drug development, it's pretty well accepted that these numbers get you on the order of magnitude, so plus or minus threefold of what you need when you look at the clinical trial. However, I guarantee you, if I'm a clinical pharmacologist, the moment I have clinical pharmacokinetic data, I never look at the HTTK data again. Why would I? I have actual human data. For most environmental compounds, there will never be a human clinical trial. So HTTK is both the first step for us, but it's also the last step. So we need to think about it differently from how the pharmaceutical industry has to think about it. And so what we want to do is compare with in vivo data wherever we can to get an empirical estimate of the uncertainty. And the nice thing about this sort of empirical comparison is basically anything that we're doing wrong, and I like to try to make 2 or 3 major mistakes a week, so I do a lot of things wrong. But anything I'm doing wrong actually will increase the estimate of the uncertainty. And so we only reduce the uncertainty by getting things right. So by actually measuring how bad we are, we know where we stand. So for a chemical-specific model, and this is the sort of work that NCCT has been working on at the EPA, and I think traditionally toxicokineticists, pharmacokinetic modelers have been doing, you want to predict concentrations and see how they compare with observed concentrations. And you consider bias, are all my points above the 1-to-1 line? So the perfect predictor line would be if all my points are on that line. If you ever have a modeler show you a graph where all their points are along the perfect predictor line, something's wrong. But hopefully they're close to that line. So are the points all underneath? Are they biased one way or another? And then you can start to consider whether I'd want to use this model to extrapolate to a different situation. That's a chemical-specific model. If you've tailored your model to a particular chemical, and that's the great amount of chemicals that are out there. But we just typically don't have in vivo data to mill this sort of graph. So instead, we can build generic models, like the one compartment model I showed you, or the generic PBTK model, and we can look at how well it does for a chemical where we have information. So hopefully there's still some correlation, but you can see that there's greater scatter. So our uncertainty is larger. And we can still try to estimate bias and say, we're still doing pretty well for chemical X. But the cool thing about a generic model, so I just said, rather than have a model that does a really good job for chemical X, now we have a model that does a crummy job for chemical X. What's the point? The point is we can also run chemical Y. Oh, hey, it turns out we also do a good job with chemical Y. We can run chemical Z. And it turns out that we always overestimate chemical Z. And then we can start to do things like correlate. Well, maybe chemical Z has a really high log P. Or maybe there's something that we can think structurally about it and start to do relations on, what classes of chemicals are we certain about, what classes of chemicals are we uncertain about. And so what's really cool is then we can use the chemicals where we do have data to tell us a reasonable guess about the chemicals where we don't have data. So the generic model lets us extrapolate to chemicals that don't have in vivo studies. And so to do this, Riza Sayre and Chris Grolke at the NCCT are putting together an in vivo database of pretty much any in vivo toxicokinetic concentration versus time measurement that they can find. And so there's 198 analytes in this right now, and so it's from EPA, National Toxicology Program, and the literature. There's rat data, there's human data, there's mouse data, and it's covering a wide range of different tissues. And so the goal, different tissues, but also different routes, so that we can start to look at different exposure routes. And it does include data from a paper that was published last year that was a cross-lab study to generate data using a standardized protocol for 26 environmental chemicals. So a lot of these are pharmaceuticals, but a lot of them are not pharmaceuticals. So these are exactly the sorts of chemicals that we want to know about. And then we're actually, basically just stealing from ToxCast project. We developed a curve fitting package that will fit all of those concentration versus time data courses using a standardized statistical tool so that we can give you volumes of distribution all fit in the same way for all those chemicals. We can give you other properties of the chemicals all fit that way. That's also available on GitHub. So what can we see if we look at predicted versus observed? Well, in a study that we published last year, we were estimating clearance from two processes. So we have the hepatic metabolism and that glomerular filtration in the kidney. And so this solid line here is the perfect predicted curve, and these red chemicals are pharmaceuticals. And what we see is that we get a decent correlation for the pharmaceuticals. R squared's not awesomest, but but it's right along the identity line. So that means that these two assays are doing a great job of capturing pharmaceutical metabolism and excretion. And then when we look at the non-pharmaceutical chemicals, so PFOA, bisphenol A, carbaryl, all sorts of propiconazole, we see that there's correlation. Actually, there's better correlation because we have PFOA down here, but there was better correlation, but we systematically underpredict clearance. And that gets to the point of the assays we use are designed for pharmaceuticals, and we're looking at non-pharmaceuticals. And so, for instance, a lot of phthalates are cleared by esterases in the gut. Well, we don't have an in vitro gut esterase assay that we're running right now, so we miss that. So we underestimate the clearance in these cases. Now, because my training's more in math than biology, this doesn't bother me as much as you might think it would. We also have an estimate of how much we underestimate clearance, and so we can just multiply this number by that number, and then we can feel like we've lined things up again. Now, certainly you'd rather know what the mechanism is that you're missing out on, but still, that's what you can do with this sort of evaluation that the databases of in vivo data let you do. All right, now I want to talk a little bit about the meat of what we've been looking at in the latest paper. So there's two basic concepts. There's variability. Variability is always there. It is a true difference between things. And so variability is like the difference in the colors in a box of crayons. The orange crayon is always orange, the pink crayon is always pink. There's just an inherent difference there. None of the crayons in this box are the average color. That might sound dumb to you, but just the most simple example I can think of is that PBPK model. Well, let's make it genderless. Well, very few of us are truly genderless. So that basically means that for the vast majority of the population, that PBPK model is either already wrong, or we say it's male and we just ignore half the population, or we say it's female and we ignore other half the population. So variability is real, and we really need to think about that. So the way we do that was developed by Dr. Carolyn Ring, now at Tox Strategies, but she was a postdoc at the EPA. And she uses the Centers for Disease Control National Health and Nutrition Examination Survey. So this is a survey, it's a rolling survey, about 10,000 Americans every 2 years. It's what I compare it to see how fat I've gotten relative to everyone else. Fortunately, America's keeping up with me. Good job, America. And but it measures biometrics like sex, race, ethnicity, age, height, weight. And these properties can actually be used to predict things like blood flow to the liver, cardiac output, kidney glomerular filtration rate. And so what Carolyn built is a tissue simulator that draws actual people from this survey, this representative survey, which the CDC kindly weights so that you can reconstruct the whole U.S. population. So you could say, Person number 3, well, they represent 42 different people. And you can actually build up the physiology of everybody in the U.S. population from this. And so with this population simulator that's built in to HTTK, you get the NHANES numbers. Now again, that seems like a lot to think about, and it is. This is what you get when you do that CalcMC oral equivalent. The Monte Carlo is simulated over these actual NHANES people. So you get one line of code and you get that whole paper from Carolyn Ring among a bunch of other papers doing the predictions for you. Now you can skew that. You can actually say, give me just the women. Give me children aged 10 to 15. Give me Hispanic population. And that's why I was saying you could actually try to build up a different country just using those subsets. Now, you're going to have extrapolation problems. There's only so many of each type of person that was sampled there. But in general, this is what we do for variability simulation. So then we also have uncertainty. So now the box is closed. So uncertainty is an artifact of our knowledge. So uncertainty is real, but it's not a property that nor data should reduce the uncertainty. And so until I open the box, I don't know what's in there. And I blame my 6-year-old here, but really it's more likely he's fed the crayons to our dog. But between the two of them, we may only have green crayons, or this may be entirely markers in there. You don't know until you open the box, and that's what uncertainty is about. And so for us, with the HTTK, one of the major uncertainties is actually this analytical chemistry. And so this is a diagram from Chantal Nicholas at EPA on the rapid equilibrium dialysis. So you have plasma on one side of it. In one well, you have a semi-permeable membrane between the two wells, and then you have just chemical in solution, and you let the two come to equilibrium. And you just look at the chemical concentration in here over the chemical concentration in there. And so when Barbara Wetmore used this assay in the 2012 paper, this assay failed for 38% of the chemicals. And the reason it fails is, well, let's say all the chemical binds to the plasma, or most of it, and we can't see it over there. And you say, what do you mean by you can't see it? Well, this is what a mass spec peak, this is a cartoon mass spec peak, might look like. And so you have an internal standard, that's kind of what tells you what 1 part per million is. And then you have the chemical peak, and you do some optimization to find that chemical peak, and you look for it. Well, if all the chemicals bound, you might not see much of a chemical peak. And you might say to yourself, well, yeah, but can't I optimize the mass spec to find the peak? And that's true if you're doing one chemical. If this peak here represents your $2 billion drug lead in the pharmaceutical industry, believe me, they will find a way to measure that peak. If we are doing analytical chemistry on 900 compounds that we don't even particularly care about any one compound, Rusty Thomas actually had to implement I think they had a 30-minute clock that you were allowed to spend optimizing. An analytic chemist hates to do crappy work. This kind of goes against their essential being. And this is basically, no, you had 30 minutes to find the peak or you move on to the next chemical. Otherwise, you're not going to get hundreds of chemicals done. So we have plenty of cases where we do have some information. We know that the chemical's really, really bound. We just don't know how well bound. So for the newest measurements that I'm going to tell you about, we actually used a new protocol. So rather than using just 100% physiologic concentration of plasma protein, we used 3 concentrations. We used 10%, 30%, and 100%. And so that actually reduces the amount of protein in the system. So if you think back to the diagram from Chantal, reduces the amount of chemicals stuck in here, it increases the amount of chemicals stuck over here. And that allows us, without doing a whole lot of optimization, to get a new protocol to better measure the fraction unbound in the chemicals. And so when we look at that, so in the new data, the median uncertainty for fraction unbound, and we express that fraction as a percent, if you just use 100%, is plus or minus 5%. That doesn't sound too bad, and that's not so bad if your chemical is 60% bound. You say, okay, maybe it's 55, maybe it's 65, I don't care a whole lot. Plus or minus 5% is kind of a big deal if your chemical is 99% bound, because then you're sitting there, well, wait, is it 94% bound, or is it all bound? I mean, you lose that sensitivity there. With this new protocol, we get that the uncertainty is now just plus or minus 1.5%. It's a lot more certain. We find that this is the width of the credible interval. So there are still chemicals that we just totally suck on, and that's actually interesting to know too. So that means the width of the credible interval for these couple of chemicals over here is, it's somewhere between 0 and 100% bound. And you might think that's useless information, but that's actually a good thing to know, because previously we would have just taken whatever the value was and said, well, it's 62% bound, and not realized it was 62 plus or minus 62% bound. So, and then we have a lot of chemicals where they're very tightly known, and like I said, the median is this plus or minus 1.4%. So we have new data. We have new data. It's actually 418 chemicals where you have fraction unbound, 467 where you have intrinsic clearance. So again, you still see that trend where even with this new protocol going down to 10% fraction unbound, we still had a bunch of chemicals that we couldn't ever find in the dish, even at 10%. So if I had to do it all again, we might do 1, 10, and 100% physiologic. I don't know. But we have a bunch of chemicals, and so these are histograms of the 418 chemicals. And so you see that, and I didn't do a good job labeling this. So what do we have here? We have a whole bunch of chemicals. Right. How do I think about this? Which is which? Red is the, red is the new protocol, and the blue dots are the old protocol. And so the old protocol had 2 peaks. One right where the red peak is. These are the chemicals that we can measure well. And then it had a second peak. The blue dots, this is with just 100%. We say, the fraction unbound is somewhere around here. With the red, we actually find out, well, no, the fraction unbounds are distributed, but we actually have values all the way down to 100th of a percent. And then we still have a peak down here of, well, boy, we really don't know. But now we know that these chemicals are below 1,000th of a percent bound, rather than just knowing they're below 100th of a percent bound. So that's actually really useful information. This is the uncertainty on both of those. And then we have here the distribution of the intrinsic hepatic clearance. And so some of the chemicals are rapidly metabolized. We didn't plot them. This is a log plot, so we don't plot any of the chemicals that can't be plotted with zero metabolism. But basically, it's a skewed normal distribution. And this is on a log scale. I guess it's a skewed log normal distribution. But your average chemical is somewhere around 30 or 40 microliters per minute per million hepatocytes. And so with these data, we now have measured in vitro numbers for 57% of the ToxCast phase 1 and phase 2 library. So what can we do having broken the chemicals down by uncertainty and variability? Well, one of the cool things we can do is that the old analysis that we used to do using SimSip or using the Carolyn Rings and Haynes simulator is look at the ratio between the median HTTK prediction and the upper 95th percentile, because that's the one that's going to be a little bit closer to the hazard up here if we're looking at exposure. Or if we're looking at hazard, this is the median that's actually from HTTK, and this is the lower 95th percentile that we want hazard-wise. And so this ratio here is what we typically saw. And for most chemicals, it is below a factor of 10 if you look at the green dots here and you just look at variability. So this is Wetmore 2012, Wetmore 2015. This is how EPA has been doing it in the past, just looking at variability. However, now we have uncertainty as well. So if we look at just the impact of uncertainty, there's actually chemicals where we didn't measure anything successfully either way, so there's no difference in the distribution. But for the most part, we see that that difference is actually less, and I would say significantly less, than the difference between variability. So the difference between a really small person and a really large person is driving more of that 95th percentile than the difference between certain and uncertain estimates. However, and so that's reflected in this blue curve, which is the green and the red together. And so for the most part, this tracks just right with the green. So that's saying that variability, for the most part, is driving the difference between the average and the 95th percentile most at-risk person. However, there are some chemicals you get out here where you start to see this ratio going up to 30, 40 times. That's uncertainty. These are the chemicals where we didn't actually know the protein binding. We had a number, but it was only certain between 0 and 100%. And that's why I said this is really useful, because we can still propagate that in, but suddenly it goes from us thinking that, oh, we know this chemical pretty well, to us realizing that, oh, crap, this data sucked. And again, if it was one chemical, we would have figured that out if you had to put your finger on any one chemical. This is an automatic way to propagate the uncertainty and measurement in and say, these are bad data. They're making me less confident in the numbers. All right, so what happens when we do this? So this is another bioactive dose to exposure plot, the blue curve, so the different chemicals along the x-axis, and in blue here we're looking at the estimates of exposure. We have the estimates of toxicity up here, and so if you just consider population variability like we always have in the past, you've got some chemicals over here that overlap, and the ones in the gray here do not quite overlap, and we can't see that yet. So I've zoomed this up, and so here's the blue, red bioactivity, and there's actually only 6 additional chemicals that we find when you add uncertainty have a potential for overlap. And so that again gets back to the idea that there's a handful of chemicals where the data are lousy, but for the most part this isn't hugely changing things, which is a little reassuring having spent a decade not thinking about uncertainty. So bringing uncertainty in, there are definitely some cases where it matters, but it's not every case all the time. All right, now I'm going to change gears from the new data just to talk a little bit about new generic PBTK models. So this is the generic model I'm showing you right now. However, we are working with a number of groups to augment this generic model to do other important routes, other important conditions, and each model is publicly released upon a peer-reviewed publication. They're cleared as part of that publication. Prior to publication, you can work with one of our models if we have a material transfer agreement in place. It partially says you understand that this model is still in development, that we're still working on it. And so we assume that there will be all sorts of problems and coding errors because I'm involved. And so we really want to get data so that we can evaluate a model. It's actually really easy to build an inhalation exposure model. There are generic inhalation exposure models out there. It's really hard to prove that it works. All right, so we have a dermal exposure route. EPA is looking at this in collaboration with Unilever. Basically, it adds compartments for exposed and non-exposed skin, so you can simulate exposure over time. We have an inhalation model that we are working on with the U.S. Air Force School of Aeronautic Medicine. And I want to show you some examples from this. So this is 2 in-prep papers, and I should have listed the other one here. We have Reza Sayer's in-prep in vivo database of toxicokinetic data, and it has inhalation exposures. We have a generic model. So this is that observed. These are in vivo concentrations from the Sayer et al. Database. And then Matt Lanakis at U.S. Air Force has this generic model to make predictions. And so there's a couple things you can see here. First, this model is not the end-all be-all perfect model. It has an R-squared of about 0.5, which I'm relatively happy with. But what we actually get is that you see skew, but you do see a huge trend. I mean, we're talking over orders and orders of magnitude here. So for all of the 50-something, is it 40? So 40-something chemicals that they're able to evaluate on, we're getting most of those points correctly. Now, if you ask us to predict a peak concentration or an area under the curve, Matt's model is actually R-squared of more like 0.8 for that. So those more typical endpoints that you'd want, this is for every single point in the curve, so that's more the shape. Now, the really cool thing about having both a database and a generic model is that the generic model allowed us to help curate the database to some extent. And so this is a recreation, but we actually saw at one point a set of points that were just orders of magnitude off the curve. And we're like, what the heck's going on? And when we looked back, the units that were listed on the axes of the graph disagreed with what was in the text of the graph. And when we put in the units from the text, all of a sudden these points were right back on the line. So having a generic model can actually help you with curating in vivo data. At the same time, using the model and the in vivo data, you can see where we can make different assumptions correct or incorrect. And so there's a red line here that's buried by the green line. And basically, the green line is, we accidentally used a 4-hour exposure instead of a 2-hour. Well, you see right away that our root mean squared error would go way down. The blue line used the wrong units, megs per meter cubed instead of parts per million. And so we ended up way up here. And so we want to get down there. So having the generic model and the database together allows you to curate the model. I mean, we've certainly seen things wrong with the model that we've improved them, but it also allows us to curate the data. So in addition to an inhalation model, we are looking at an aerosol exposure model. That will be very important for occupational exposure. And we're looking at a human gestational model. So that would be a generic model for both the fetus and the mother, and the fetus would grow over time. And so it's human gestational because the rates are very specific. And actually, Dustin Capron at the National Center for Environmental Assessment at EPA just published a paper on a set of empirical models for all of the growth of all of those different compartments and allowed us to, should allow us to parameterize the PBTK model for maternal and fetal exposure. That model, an earlier version of it, is currently being used by Dr. Annie Luman at the FDA. She was just presenting this at the teratology meeting on Monday, I think, or Wednesday, I don't know what day. But basically what she is able to do with this generic model is start to look at things like what is the difference between the drop in concentration for a parent, or for the chemical exposure in the mother versus what the fetus sees. And so what she's finding is relative insensitivity to parental changes in exposure. So you might think, oh, the chemical's cleared out of the mother, but it hasn't cleared out of the fetus quite as much yet. And so that's going to depend on time. It's going to be complicated. But basically, we have agreement with Annie, and we're working on developing this sort of work. All right. This probably seems a little overwhelming. We've worked really hard to make it overwhelming for half a decade now. So you can mostly HTTK is documented, and within R you can type help, and pretty much anything with an HTTK you can get help. So help HTTK, you get a generic page, you can start clicking on links, you can actually go directly to papers. There's a list of every function. There is something called vignettes. These are how-tos to make figures, and for the last several years our group has actually put out a vignette for every paper we put out, so you can see how we made all the figures that we used R for. And if you want to know how to make figure 12 from whatever paper in 2018, that code is right there so that you can run it. I was actually working on creating a vignette for paper this week and realized that I'd made an error, so it's useful to us as well, but basically you can see how we do everything. There's Carolyn Ring's vignette on how to make an activity to exposure ratio plot. Finally, people ask me all the time, does my chemical have HTTK data? And so if you're within HTTK, there are functions. There's a get chemical function. It'll tell you what data you need. And then here's just some examples on how to see is your chemical in there or not. All right. Do want to discuss limitations. I'm not trying to be a car salesman here. There's a lot of things that frustrate me about the state of in vitro toxicokinetics right now. So first off, there's issues with oral absorption. Model assumes right now 100% absorption. The in silico models that exist for that have pretty much been shown not to be really relevant to environmental chemicals. And so Greg Honda is developing a QSAR and looking at new in vitro data for toxic gas chemicals, and we'll try to implement that as part of HTTK in an upcoming publication. Hepatic clearance is certainly limited. It's also not isosome specific. We're using that 10 donor pool, and we're actually only looking for 2 to 4 hours. So if you have a real low turnover chemical, we might not see any metabolism in 4 hours, but there might be metabolism that happens in 24 hours, but all our hepatocytes died. We know that isozyme abundances vary with their activity and age and ethnicity, and we just don't know what isozyme is involved. Barbara Wetmore did do some work in 2014 for some specific chemicals, but that was like as much work. It was like as much work to do 10 chemicals as it was to do the 200, because she had to repeat all the work one isozyme at a time. ADMET predictor can predict clearance for some enzymes, but again, that's on a training data set that's mostly from pharmaceuticals. Plasma binding assay continues to drive me up the wall, but then we also have issues of, plasma protein concentration probably varies from person to person, but I don't believe we have very good models for that right now. And then plasma protein concentration is really generic. Your plasma has lots of different proteins, and so we assume it's mostly albumin, but we don't know. It could be AAG. Both of these proteins vary differently in the population, so it's just like the enzyme variability problem, and we don't have the data to do that. And then analytical chemistry. If we're going to do HTTK, we have to develop a method. Typically, that's been LC or GC, and if we can't develop an LC or GC method for a compound, we can't give you HTTK numbers for it right now. Now, they're working to develop QSARs. So Nisha Seitz at the National Toxicology Program used Simulations Plus and actually published a data set of predictions for every Tox21 chemical. And that's actually available in HTTK. There's a function load sites 2017. You load all the numbers from a 2017 number and you have those QSARs. And so we are working to develop ways to get around that, but you have all the domain of applicability problems you'd have of, well, I only have data on chemicals where analytical chemistry worked. Is there something about the chemical that makes analytical chemistry work for that chemical, that makes it different? So just to wrap up, HTTK allows you to go from high throughput screening to human relevant doses, mgs per kgs per day. And we are at EPA, we've just submitted a paper this month on new data, and that new data will be available in the next week or two as a new version 1.10 of the HTTK R package. And so that will be out there for everyone to use publicly, and find our mistakes and email us relatively kind emails about what we've done wrong. Overall, in our new analysis where we compared uncertainty and variability, variability was still the big driver of the distributions, that 95th most sensitive population, but uncertainty can sometimes matter. And so, in particular, as we develop new models, we really need to compare predictions versus observations. And so that's where this new database of in vivo concentration versus time data being developed by Reza Ser and Chris Krolke is just going to be absolutely essential. It will be a public database, and we are hoping, if it's a public repository, to entice other people to contribute data to that. So I just want to, again, thank all the people working. So Mark Spear joined the group this year, actually waited out a shutdown to join the group and help out, doing all things HTTK. Greg Honda's currently working on oral absorption. He's worked on lots of other projects. We have a human gestation group. Ciprotex has done endless measurement for us and really put up with us. The structure-based predictions group involves a lot of different people. There's a dermal modeling group, TK database group, and then inhalation group. A lot of that work is happening at the U.S. Air Force School of Aeronautic Medicine. And I do want to thank my longtime collaborators, Rusty Thomas, Barbara Wetmore, and then Dave Murphy, Kathy Koutros, and Ann Richard for getting all the chemicals everywhere. This is just a small part of the ExpoCast project. That's a 4-lab-centered EPA. I lead that project with Kristen Isaacs and Kathy Dionisio, and we have a number of external collaborators. And I hope this work comes across as having been involved with a ton of people, because it has, and I really appreciate everyone's help. These slides will be publicly available. I will now read to you each reference. No, not really. And no, I think we hopefully have time for a couple of questions.
Okay. Yeah, it looks like we've got a few in the chat.
Cool.
So, we got one from Nazanin. They want to know, they've also read the HTTK paper. In the validation step in your paper, you used in vivo data that was gathered and cited in previous papers. Is this in vivo data in human or rat? And then one,
yeah. So it always depends on which paper, but there was a Wambaugh 2018 paper where we used rat. And typically we have used rat because there's just more rat data available for the sorts of compounds we want to do. If you think about it, if I have a drug, I can ethically do a human clinical trial and try to figure out the pharmacokinetics, because that's actually going to benefit someone. If we're talking about a plasticizer that, the exposure is unintentional, we tend to not have human clinical trials for that. So a lot of the evaluation we have done has been in rat, but the concentration versus time database that Reza Ser is developing includes both human and rat. And so for the lung inhalation model, it actually broke down about 50-50 in terms of rat chemicals and human chemicals. And Matt Linakis did separate evaluations. And fortunately, in that case, the gas inhalation model behaved about the same. Now, and this is an aside, but for aerosol inhalation, the geometry of the rat nose is going to be a big confounder, and so I would expect that we'll do a much crappier job for aerosol inhalation when we look at rat versus human. And we're always going to err toward doing a better job with the humans than we are with the lab animals.
The next question from Elena. It says, the diagram looks like the generic model incorporates diffusion, limited tissue transfer. Is that correct?
Great question, and I meant to say that. We only have perfusion-limited tissue, so that means that we don't model the chemical kind of slowly migrating into tissue, even though that happens all the time. And then especially if you think about chemicals diffusing into bone or something like that, that'd be a big thing that you'd want to have. But what we suck at predicting right now with QSARs or any other method are really rates. So if you think about what we're measuring in the in vitro assay is a metabolism rate, because we can't predict a rate. We maybe could predict the possibility of metabolism or not, but it's really hard to predict a diffusion rate. So right now our models assume that you instantaneously come to equilibrium, which is a pretty big assumption. But again, that's why we don't get a perfect correlation when we look at the data, but we've at least quantified what that correlation is, and we know, if somebody can build a model for diffusion, we'll immediately adopt it and evaluate how much better it makes our models.
Okay, cool. And from Carol, she wants to know, what plans do you have to consider the hazard/risk associated with metabolites?
So first off, there are a small subset of metabolites that you can procure as standards and are actually part of the ToxCast library. And so we do have a project in mind for that small subset to actually do a parent metabolite model, and that'll be great for that half dozen chemicals where we can do that. That's not going to help us in most cases. So we are trying to develop the ability to look at how well software can predict even the formation of metabolites. We've got a project looking at chemical suspect screening analysis in these metabolic assays to see how well did we predict the formation of different metabolites. But right now, it's still an open question because we don't have an easy way to get a lot of the data. And one of the biggest bottlenecks is simply not being able to go to a chemical supply store and say, give me a jar of metabolite 3 from this compound, because they're formed as metabolites. We can't necessarily procure them to even do the testing that we'd want to do on them. But we are building a generic parent metabolite model for the half dozen chemicals. And so as people get the data in the future, maybe we'll be able to use that model.
Looks like we do have a couple people typing, but are there any questions in the room while they're working on it?
I have one. So you talk a lot about in the paper with my cues how well we can predict pharmaceutical-like compounds versus non-pharmaceutical-like compounds. Do you have a set of ranges of physicochemical properties that you can use to define what a pharmaceutical-like compound is versus not, so that you could start to stratify the chemicals and then the HTTK assumptions you apply to them?
So that's a great question. So a collaborator in the National Exposure Research Lab at EPA, Catherine Phillips, has made some great advances at predicting the use of chemicals. And so she can actually predict, is this chemical just from structure, is it going to be useful as a hair dye, is it going to be useful as a solvent, things like that. And so she has not published this yet, but she has developed a model for predicting this. Is it going to be a pharmaceutical or not? And so that model would allow us to, it's not hard and fast rules like the rules of 5, the Lipinski's rule of 5 or anything like that, but it would instead give you a probability of 80% chance this is a pharmaceutical or 3% chance it's a pharmaceutical. And so that would be the way I would go forward with it, is to consider that sort of prediction of, is it a pharmaceutical or not? And I just want to, when you think of something designed to be a pharmaceutical, it's designed to, most drugs are cleared from your body on a relatively normal scale. You don't want to take one pill every 6 months. You want to be able to get off the drug or get back on it. You also don't want to have to take a pill every 3 minutes. So you're already, bracketing your clearance, whereas we certainly get exposed to environmental chemicals that either have a half-life of a year or a half-life of minutes. And so that's just one example of where this pharmaceutical nature, by design, those chemicals are bracketing in at a very specific range.
So we got Charlene in the chat, and they say, OCSP is also a collaborator as well as OCSPP. We are interested in direct regulatory applications of toxicokinetic data in dose setting. Speak to greater collaborations with OCSPP. I'm not sure.
It's a little, hi, Charlene. A little above my pay grade, but so what I am aware of is that OCSPP is actually funding the development of data. When I was mentioning that data are being developed in alternative species, so they are actually looking at mouse and fish in addition to human clearance, so that you would be able to then, rather than use human data and extrapolate to a human, or and extrapolate using mouse physiology, you'd actually have mouse-specific data that you could use for protein binding and clearance. And they do vary decently between humans and mice, and humans and rats. Well, actually, I guess we don't know how well they vary between humans and mice. We know they vary between humans and rats. So, for the endocrine disruptor screening program, the Office of Science Coordination Policy, OSCP, has been developing data like this for quite some time and actually funded a large amount of the data of the 400 new chemicals that we're presenting there.
Okay, so we've got another one from Nazanin, and they say, in Wambaugh 2018 paper, you define a triage method to define the confidence of predictions for each individual chemical. This is an RF model that uses a number of parameters. What are those parameters that define the confidence level for predictions of a test chemical?
Okay. So, and so that's the 2015 paper, and that's actually one on. Yeah. Okay.
Sorry.
No, it's cool. So just the reason I mentioned the year, I'm not at all trying to quibble on that. That's actually built on everything as I understood it in 2014, which, the good thing about life is that I know a lot more than I did 5 years ago. The bad thing is that that's the last time I did that analysis, and so I'm dying to repeat this analysis at some point. However, very nicely set up for the one thing that I really wanted to say is, so the first predictor for how well HTTK was going to work was how successful is the plasma protein binding measurement. So there's no big surprise then that over the last 5 years we spent a lot of time improving that measurement. However, other things that were predictive included, is it a substrate, especially for a predicted substrate for bile transport? And so we've done some work looking to see if we could fix that up, and that didn't pan out as much. That's why you haven't seen that paper yet. But then we have also found that we can't predict perfluorinated chemicals. And that's one thing that we often get asked is, should we be using HTTK for PFAS chemicals? And one of the easiest predictors we had was, if your chemical was perfluorinated, HTTK sucked. So unfortunately right now that's just not something we can do super well, but that was one of the predictors out of that. And like I said, I'm always happy to be emailed questions, but that, to the best of my ability from that paper, that's what I remember as big predictors.
Okay, well, I think we're already about 5 minutes over. So as we said, if anyone has any follow-up questions, you can feel free to email me at hanf.alexander@epa.gov or John.
Yep. Thank you.
Appreciate it. Hope to see you all next month.